they found that for those people who had even trace levels of ketone production, they had improvement in their cognition and improvement in mood and energy. The improvement in cognition is significant because not one medication trial with Alzheimer's disease has ever shown improvement in cognition. And this was in just 6 weeks. In just 6 weeks, they found a statistically significant difference in cognition, an improvement in cognition in people with Alzheimer's disease who could be on a ketogenic diet.
Welcome to the Fundamental Health Podcast. I'm your host, Dr. Paul Saladino. This podcast is the result of my relentless search to understand and correct the roots of chronic disease and illness. In this podcast, I will share with you everything I have learned about how to live the most healthy and radical life possible. Thanks for joining me on this journey. Well, hello everyone. I hope you guys are having an awesome week, and I am super stoked in the way that only a surfing doctor in San Diego who rarely wears his shirt on Instagram could be stoked about today's podcast. I have an amazing conversation with Christopher Palmer, MD. He is a physician at Harvard Medical School. He's a psychiatrist. He got his medical degree from Washington University School of Medicine and did his psychiatry residency at McLean Hospital and Massachusetts General Hospital at Harvard Medical School, which are certainly the most prestigious places in the world that you could train for psychiatry. It's pretty much the creme de la creme. He is an incredible individual, and he is currently the director of the Department of Postgraduate and Continuing Education at McLean Hospital, which is associated with Harvard Medical School, and he is an assistant professor of psychiatry at Harvard. For 20 years, he has focused his clinical work on treatment-resistant cases. These are cases of depression, anxiety, bipolar disorder, schizophrenia that don't really respond to traditional therapies. He has been researching common comorbidities of mental disorders and metabolic disorders such as obesity, diabetes, heart disease, insulin resistance, and recently, what we talked about a lot in this podcast, was his pioneering work of the use of a ketogenic diet for psychiatry. Whoa, so cool, right? In the treatment-resistant cases of mood and psychotic disorders. As you'll hear in this podcast, we talked a lot about psychotic disorders on a continuum, on a spectrum of bipolar disorder to schizophrenia. And many of you will know that I did my residency in psychiatry, and so all of this is very near and dear to my heart. And it is so cool to see somebody in an academic medical center using a ketogenic diet to treat these illnesses. And some of the cases that we discussed toward the end of the podcast, check the show notes if you want to know exactly when that is, are quite striking. I mean, Dr. Palmer has seen a 70-year-old woman with schizophrenia and psychotic symptoms for 50 years resolve completely on a ketogenic diet. So we talked all about that. We talked about the sort of the mechanistic basis of psychiatric disease and illness. And this podcast is going to blow your minds. It's a long one because Chris and I geeked out, and we are psychiatric brethren and have a shared interest and passion for correcting the paradigm within this field of medicine that is in so much need of improvement in the way that we treat these mental illnesses. So I think you guys are really going to enjoy this one. It is really groundbreaking, incredible stuff, and I'm so grateful that Chris took the time to have this conversation with me. This podcast is sponsored by the amazing White Oak Pastures, you guys. I'm going to tell you more about this after the episode, but you should come to White Oak Chella, which is our gathering at White Oak Pastures. It's going to be December 14th and 15th in Bluffton, Georgia. Listen to the end of the episode to hear about that. White Oak Pastures is a 6th-generation family farm. For 150 years, it has been in the Harris family, now run by Will Harris and his daughter Jenny Harris. They are pioneering the way. They are one of the savory hubs using the methods of Alan Savory to do regenerative agriculture. And as I've mentioned before, are returning more greenhouse gases to the soil they're sequestering more greenhouse gases than they are producing, and they are so interested in creating the best quality products they can. They do completely grass-fed, grass-finished beef. They do pasture-raised pork, which is Iberico pork, which is out of this world. They do lamb, they do chicken, they do turkeys. You can order your turkey there for Thanksgiving. It's an amazing, amazing place. The meat is fantastic. We are figuring out in my partnership with them how to get shipping to the West Coast better. If you are in the middle of the country or the eastern, southern part of the country, the shipping is no problem for you. But if you are on the West Coast and you see the shipping is quite expensive, that's because we are still in the process of helping this amazing farm get out to the West Coast in an easier way. But I love them. I am so excited to be partnering with them. I'm so excited that you guys are learning about them. And I'm so excited that they are being such a great example of the way that ruminant agriculture can be so life-giving for the environment, in stark contrast to the way that monocrop agriculture is destroying our soils. So check out White Oak Pastures, check out their environmental impact, check out the way they are leading the way. Use the code CARNIVOREMD on their website until October the 7th for 10% off your order. And you have a few more days to do a steak dance on Instagram. They are giving away $100 to the best steak dance. And listen to the end of the episode. I'll give you more details about White Oak Cello, which will be our gathering of the carnivore and ketogenic community at the Bluffton Farm for White Oak Pastures in December. And I can't wait to see you guys all there. This podcast is also sponsored by my tribe, my buddies, my friends at Ancestral Supplements. These guys have been leading the way in producing grass-fed, grass-finished organ meats, which are freeze-dried and packaged into easily convenient gelatin capsules. Their organs are sourced from New Zealand, from extremely clean farms that are all grass-fed and grass-finished, and you can get all sorts of organs. They have prostate, they have lung, they have liver, they have spleen, they have pancreas, they have thymus, they have collagen, they have tracheal collagen, which is amazing. They have the new intestines and gut supplement. They have so many good things. I think that the lung one is really interesting. You guys should check that out. All the cool vessels in the lungs. They have heart. There's really something for everybody there. I think liver is one of the most amazing ones. If you're not getting real liver, then the freeze-dried supplements are a fantastic option and will significantly increase your nutrition. My super, super cute 1.5-year-old niece gets these on her food, and she's going to be a genius. I know she is. But anyway, use the code SALADINOMD at the Ancestral Supplements Shopify site for 10% off, and check out their stuff. They are, like I said, leading the way on this stuff. They are putting back in what the natural world has left out. They are amazing. AncestralSupplements.com. I appreciate them very, very much. All right, you guys, without further ado, Chris Palmer, MD, an amazing pioneer in the world of psychiatry, my buddy, my brother, fighting the good fight. Enjoy this one. All right, Dr. Chris Palmer, my friend, welcome to the podcast. It's so good to connect with you.
Dr. Saladino, thank you for having me.
Oh, you can just call me Paul, my man. Everybody calls me. You can call me Dr. Carnivore, maybe.
All right, you can call me Chris.
All right, Chris. So, it's really awesome to have you on the show. There are so many exciting things happening in the field of ketogenic diets in terms of psychiatry and overall health. And you are really leading the charge in the psychiatric world right now for ketogenic diets. So thank you for coming on. And I think people are going to be really excited about the kind of stuff we're going to talk about.
Awesome. Thank you. I'm beyond excited about it, and your listeners will find that out soon enough.
I know. I get the same way. I'm Italian, so I just start moving my hands around and gesticulating and getting all excited, and people can tell. They're like, oh my gosh, your eyes get so big. And I think you are the same, my friend.
I am, and I'm not even Italian.
What's your ethnicity?
It's American mutt. We like both sides of my family had been in the United States for over a couple hundred years. So I'm from the Midwest, and I am a purebred American mutt. Like I've got a little of everything in me.
But you're still excitable, and you still get excited and wide-eyed about all this kind of things.
Absolutely. Sometimes mutts are the best dogs.
They are the best dogs. Absolutely. So you're at McLean Hospital, which is one of the Harvard hospitals, and people know that I just finished residency, but they may not know that I interviewed there. And before we jumped on the podcast, we were kind of joking and talking about this. So I, in retrospect, kind of wish that I'd done residency there, because we would have gotten to work together and might have gotten to do this podcast a bit sooner. But, you know, I just want people to understand that MGH, Mass General, and McLean are without a doubt the most prestigious psychiatric hospitals in the country, if not the world. So this is really exciting that at these sort of bastions of psychiatry, we are starting to see ketogenic diets being used in treatment. So let's just set the stage for people and talk a little bit about what is known in schizophrenia, depression, anxiety, as far as what is going on in the brain and why the ketogenic diet might be relevant in this situation.
Yeah, no. So it it turns out there's a lot I could say about this. So let me kind of do the basic framework. So most people, when they think of depression, most people think of it as one of two things, or maybe one of three things. So option number one is it's just a whiny, complaining person. So it's somebody who just needs to suck it up. You know, everybody's got hardship in life. Everybody has bad times. Everybody goes through a breakup. And these people who like say they're depressed, they just need to, you know, get tough and stop complaining so much. And maybe some of them are even trying to scam the system and get on disability and, you know, all this other kind of stuff. So there's that one group of people. And then there's another group of people where most people do think of it as it's all psychological and social stuff. So, you know, they came from a bad home, they got abused a lot, you know, their parents were jerks, they live in poverty today, they have a lot of adversity in life for whatever reason, and maybe a lot of it's not even their fault. There's no way they could have controlled it. There's nothing they could have done about it. And so it's kind of like, well, yeah, I understand why they're depressed. Sucks to be them because they've got a shitty life. And wouldn't you be depressed if you had a shitty life like that? And then there's another group of people where, you know, like they have pretty much everything going for them, or they've got a decent enough life. And then out of the blue, they get cancer, or they have a back injury, or nothing happens, nothing at all happens. And they get sometimes severely depressed. They can't get out of bed. They lose their will to live. They, even when they're tough and hardworking, they might force themselves to get out of bed and go to work and do what they're supposed to do. But everybody around them is like, oh my God, what happened to you? Like, you're not the same person anymore. There's something wrong with you. Like, come on, snap out of it. Like, what? And the people themselves will say, I don't know what's wrong with me. Like, I don't know why I feel so shitty. I don't know what's wrong. Like, I know I've got a good life. I know I have a lot to be grateful for, yet I don't feel grateful for anything. Like, I just want to die. Like, why am I even alive? And they have no idea why those things are happening. And then we say those people have a chemical imbalance. So those people have a chemical imbalance. And when we say chemical imbalance, what we mean are neurotransmitters. So those are things in the brain that, you know, molecules or chemicals that go between cells and send signals. And we've known for decades that people with depression do actually have changes in the neurotransmitter kind of activity level of brain cells. And we know that from all of these fancy neuroimaging studies. We know it from like taking, you know, samples of the fluid from their spinal cord. I mean, we know it from all sorts of studies. And it's pretty clear that neurotransmitter levels are, in fact, slightly altered or different. And that has been the basis of a lot of the medication treatments that we use, is that these medications change these levels of neurotransmitters. And for some people, the medications actually work. So for some people, these medications make their depression better or make their anxiety better. And, you know, it turns out that like about 13% of the United States population right now is taking an antidepressant. So lest someone think this is a rare thing, or this, you don't know anybody with depression like that. Well, 13% of the entire United States population right now is taking an antidepressant. So more than likely, you actually know a lot of people who are taking antidepressants. Now, they might be ashamed of that. They might be embarrassed by it. They may not talk about it, but you probably know people. And so that's depression. And then when we get to like what are usually called the more serious mental disorders, so bipolar disorder and schizophrenia. So, bipolar disorder, for people who don't know, is, a combination of episodes of depression and episodes of mania, which is kind of the opposite of depression. People get wired, they get sometimes happy or sometimes just revved up and irritable, but their thoughts are speeding, they're not sleeping, all these kind of things. And a lot of times people with bipolar disorder also get psychotic. So they have hallucinations, they have delusions. And that's really the hallmark of schizophrenia too, is hallucinations and delusions. It turns out that, in the last several years, I lump those disorders together, and I lump them together for scientific reasons. So we actually have a lot of evidence now that those disorders are in fact probably the same disorder, but they're on a spectrum. And so there was this group of researchers at multiple sites. They are some of the best researchers that we have in schizophrenia and bipolar disorder. They got together to like once and for all test all these people with bipolar disorder and schizophrenia and figure out what is different about them. And they did genetic studies, they did neuroimaging studies, they did EEGs, they did all these kind of batteries of questionnaires. They looked at their family members, they looked at blood, they looked at levels of inflammation. They did every test they could think of. And at the end of all that research, millions of dollars spent from the federal government to figure out once and for all what is different about schizophrenia and bipolar disorder, nothing. They couldn't tell the difference. There was no marker, no biological marker that separated the groups by diagnostic category. And clinically, for any mental health professionals, we've all kind of known this for decades. Like people who start off with bipolar disorder often turn into what we call schizophrenia. Like their psychotic symptoms maybe initially go away and they do okay, but then over time, the psychotic symptoms can keep coming back and start lingering longer. And then at some point, we're like changing their diagnosis from bipolar to schizophrenia. Well, does that mean they unfortunately developed a brand new second disorder, like completely independent and unrelated from the other? No, it means that it's just a spectrum of the illness. And when I say a spectrum of the illness, I take that seriously, and I don't mean to minimize it. So there's a difference between being psychotic all of the time and having mood episodes and not being psychotic. So those are very different disorders. But, with every other medical disorder that we have, it's the same deal. You can have diabetes and not even take medication and manage it through exercise and a decent diet, or you can be diabetic and have heart failure, kidney failure, liver problems. You can be a mess and disabled and near death. And we call that all diabetes, yet the symptoms are very different. The suffering is very different, whatever. The consequences are very different. So I don't mean to minimize that there's no difference between schizophrenia and bipolar, because there clearly are differences, but it ends up being circular logic. It's like the people who are hallucinating all the time, we call them schizophrenic, and the people whose hallucinations go away every now and then, we call them bipolar. Okay, well, but it's probably the same illness, just like diabetes. And so it, when people think about those disorders, most people don't think of those people as whiny, complainy people. They don't think of them usually as trying to fake it. Every now and then they might get accused of something awful like that. But for the most part, people who have bipolar disorder or schizophrenia, they're thought to have a genetic disorder, that these things run in families. So everybody thinks they're genetic, and or it's clearly like a biological disorder. and it's definitely due to neurotransmitters. It's definitely a chemical imbalance. So they have a chemical imbalance in their brain, probably because of a family history or biological thing. We don't really know exactly what causes it, but you know, they have a legit disorder. They're legit. They're clearly legit. Um and so most of our treatments over the decades have focused on medications, and they're medications to balance the imbalanced neurotransmitters. So they're supposed to, you know, change the neurotransmitter levels in a way that's somehow helpful and somehow restores health. For anybody who's known anybody with a chronic mental disorder, you kind of know we don't know enough, and our treatments right now, you know, I don't want to bash them too much because I do think that they keep people alive sometimes when they would probably be dead. I think they keep some people out of jail who would otherwise be in prison. Um, I think they can sometimes prevent homelessness. So some people who might be so ill and so disabled that they would just be living on the street, I think sometimes the medications and the treatments that we have can keep them safer, you know, hopefully offer a better quality of life, like in a group home or in their parents' home, something like that. So I'm not here to bash psychiatry. I'm not here to bash our current treatments because I think in general, people are doing the best they can, and psychiatrists for the most part are doing the best they can. And most of us went into this field because we actually really do care about these people. Like we, you know, even though the rest of society sometimes looks down on them or makes fun of them or is afraid of them, like we're not afraid of them. We don't look down on them. We like see them as suffering human beings, and like we want to help them. And but the help that we're offering is abysmal. Like
That's exactly the word that I was going to use. That's exactly the word that I've used.
let's just call it what it is, and
let's call a spade a spade.
Let's call a spade, and let's get real, and let's get realistic. And you know, we have really good data on this. I talk about this a lot. You know, there was one study that followed 6,000 people with schizophrenia for 3 years. They were all treated at high-end academic medical centers. So they're supposedly getting the best of the best care. And over a 3-year period, only 4% of them, 4%, had what they defined as a recovery.
Right.
And they defined recovery as your symptoms go away, your quality of life is at least adequate. Like it doesn't have to be good. It just has to be adequate. And like, I don't know about you, I'd like a good quality of life myself. But they're settling for adequate here. And then the ability to function in life. And that means, for most people, that means going to work, having a job, or going to school if you're of that age, and being able to do those things, and being able to kind of take care of yourself and be an independent human being, an independent adult in society. Only 4% got that. And more than likely, those people's diagnoses probably got changed. And then they stopped calling them schizophrenic and said, oh, you're doing so well, you must have bipolar disorder instead of schizophrenia, or whatever. And those are the kind of tricks that we play in psychiatry. We change the diagnosis when symptoms change or whatever. But the bottom line is that anybody who's known anyone with any of these disorders, you know, we need better. We need better solutions. We need better treatments. We need to understand these illnesses a hell of a lot better than we do right now.
Exactly. And in my experience, the treatment paradigm for schizophrenia, for depression, for bipolar, it hasn't really changed much in the last 40 years. We are still treating neurotransmitters. And I love how you highlighted this. And I want to recapitulate this for people. What Chris is saying is that we in psychiatry and in medicine are still using a paradigm that's 40 to 50 years old that these disorders are based primarily on neurotransmitter derangements. And though, as Chris is highlighting, there do seem to be some changes in the way neurotransmitters are working in the brain in depression, anxiety, schizophrenia, bipolar, it's becoming exceedingly clear that these are not the end all and the be all, and that there's more to this story. And then the more important, interesting question, which both Chris and I are sort of fascinated by, is what the heck is causing the neurotransmitters to be unbalanced? And rather than accepting the sort of subtle view within medicine that it's due to genetic deficit, genetic defects, mutations, or a bad family history, what I think is happening in medicine, or needs to happen more across medicine in general, in psychiatry and in other specialties, is that we discard the sort of it's your family history excuse for why something is wrong and start looking deeper into why things are disordered, looking for the root cause, right? The why behind the why. And so in psychiatry, the why behind the why is very fascinating. So the why behind why neurotransmitters are disordered is what we're talking about today. And that is where things really get cool, because we are starting to understand, and I think that it's not even mainstream psychiatry yet. When I was in residency, nobody was really talking about why neurotransmitters are disordered, or neuroinflammation, or insulin resistance in the brain, or mitochondrial dysfunction in the brain, or disordered glucose metabolism in the brain. But I think that that's where the wave is going to be. That's the coming wave that hopefully we're both a part of. But I'll just add that when I got into residency, when I started residency, I was not excited about meds at all. I'd read The Emperor's New Clothes, like there are all these books about, anatomy of an epidemic, and these sort of skeptical books, these anti-psychiatry books, calling out some of the things that Chris is highlighting, that if you look at the data for antidepressants, it's not really that good. It's not really that often that when we treat people with antidepressants, they do a whole lot better than placebo. There definitely are some people who do better on antidepressants, but for the majority of people that I've treated with antidepressants, they don't really work that well. They have bad side effects, etc. There's a whole nother trial that we don't really have to go into, called STAR-D, that talks about this. But in that trial, it was only the people that had moderate to severe depression that even had improvements in their depressive symptoms relative to placebo. So there's a big placebo effect with depression. And as Chris is describing, in schizophrenia, we basically are not improving anyone's life at all with the medications. We may be keeping them out of jail. We may be preventing them from being homeless, but we're doing our best, and psychiatrists are doing their best, but our model, our paradigm needs to change, and the way that we treat these disorders needs to mature, because clearly just being focused on meds that address the neurotransmitters is not getting us where we want to be.
Yeah, no, I couldn't agree more. I think, I'm a big fan of like common sense. I think that's from my Midwest upbringing. But I'm a big fan of common sense. Like if something's working, hey, who am I to stand in the way of something that's working? And so when pills work for people, I'm all for it. Do I still prescribe pills to people? I do. And make no mistake, and like even when I'm using dietary interventions or other interventions with patients, sometimes they go through episodes, rough patches, whatever we want to call them, where things are out of control, things are dangerous, things are, somebody's gonna kill themselves, somebody's gonna get killed. So, I mean, bad stuff can happen with some of these disorders. And in those instances, I'm more than comfortable and happy to use medication. And even if I see it as a setback in the treatment, I'm like, well, better alive and set back for a little bit. And we'll work on, maybe see if we can get you off this, or see if we can adjust it, or maybe it's just a temporary thing for, a week or something while we're getting through this rough patch. But better alive than dead. And so, at the end of the day, I'm pragmatic, but as you said, with like the antidepressants. So, I think one of the most staggering statistics right now that a lot of people still don't realize is that major depression is now the leading cause of disability in the United States but not only in the United States, it is just in the last 2 or 3 years taken the lead role for disability throughout the world. And these people are getting treatment. They are not disabled because they don't have access to mental health care. They're getting mental health care. They're getting lots of pills. They're getting psychotherapy. Some of them are getting ketamine injections. Some of them are getting ECT, and they're disabled. It's the leading cause of disability. So for any of your listeners who are hardcore Republican and want everybody to be a tax-paying citizen, you need to get behind this because if you want to get those people working again, and you want to get, because those people actually want to work. I've had patients in my office. Yeah, a lot of people think, oh, if I got disability, I'd be all happy. They're all set. They don't have to do anything. They just sit around and loaf all day and, live off disability. Well, number one, disability is like poverty level kind of living situation. So let me just like clear that up for anybody who thinks that like it's great to have disability. It's really not great. Most of the patients that I treat are struggling to like pay their bills. They're struggling to eat every month. And so it's not a great existence. But more than that, like I have had patients in my office time and again in tears because they can't work, because they desperately want to work. They want to respect themselves. They want to earn other people's respect. They want to be a contributing member of society. But their illness, whether it's chronic depression, whether it's schizophrenia, bipolar disorder, or whatever, their illness is preventing them from doing it. Like, no matter how hard they try. I had one patient with schizophrenia. I mean, she was really upset about this, and she was in tears many times over, I just want to work. I want to have my own money. I want to make my own money. I want people to respect me. And we tried on 4 different occasions to get her a job. And we weren't shooting high. We were going for bag groceries in the supermarket. Clean people's houses. Just go to their houses and clean for them. You can do that on your own time schedule. You don't have to, and every single time we got her a job, and we got her some jobs. She didn't last more than like a month or so because her symptoms would start getting worse. She'd start hearing voices even more intensely. She'd get paranoid. She was like accusing the managers of stealing money when they really weren't stealing money. And, that creates a whole mess. And, and then she gets herself fired. Like, so even though these people want to be productive citizens, even though they want to work, even though they, want to have self-respect, it's hard for them. And we need better treatments. I mean, a lot of these people, like I said, they're coming to us begging for help. They're coming to us saying, Doc, I will do whatever you tell me. Just tell me something that will actually work, and I will do it, no matter how horrible it is. So, oh, you're going to give me a pill that's going to make me gain 50 pounds? Oh, well, I'm not real happy about that, but if that's what it's going to take to get me better, I'll take your pill and I'll gain the 50 pounds. So I can't tell you how many times I see that scenario play out. So we, the psychiatrists, dole out our pills that make everybody gain 50 pounds. And then 50 pounds later, which for some people only takes about 6 months or so. It doesn't take a long time to gain 50 pounds with these medicines. And then 6 months later, they're still seriously depressed or impaired by their illness. They're still disabled. They're still a mess. And then we're trying new pills, and we're trying, oh, well, this one's going to make you gain another 75 pounds, but just go ahead and take it. We don't have anything else to offer you. Like, I am such a big fan of the work that I've been doing lately to be able to offer people, oh, this intervention is going to help you lose some weight, and it might actually get you non-disabled. It might actually get you better. So, like, what's not to love about that? It's really hard to do, and I'm not going to sugarcoat that at all. Ketogenic diet, in particular, the one that I'm talking about, is Extremely difficult to do. Extremely difficult to do. It's complicated. People need a lot of education. They need a lot of support. But I can't tell you how delighted I am to be able to look some people in the eye and say, I've got a treatment for you. It's going to be really hard. You're going to have to work your ass off. You're going to have to learn a lot. You're going to have to be disciplined. Yeah, but I've got a treatment for you, and you're going to lose some weight as a bonus. And that is a totally different model of psychiatry compared to what is practiced, not just here in the United States, but throughout the world.
Total paradigm shift. So I want to talk about the ketogenic diet and psychiatry. Before we do that, let's talk a little bit about the cool things that are being discovered now about what might actually be driving these psychiatric illnesses. And then I think people will be able to understand why the ketogenic diet might be working and why a carnivore diet or a ketogenic version of a carnivore diet might be working. So what are we discovering now? I mean, this was sort of my revelation in residency, that there's so much more happening in the brain and the body than just neurotransmitters being disordered or imbalanced.
So my big focus right now is what I'm calling the connection between metabolic and mental disorders. So metabolic disorders, most people think of metabolic disorders as obesity, diabetes, and cardiovascular disease. There are definitely people who lump some other diseases in that model, but mainstream medicine doesn't. But some people put cancer into that group. Some people put Alzheimer's into that group, and that's the evidence for that is increasing. Some people put lots of other disorders in that group, but the three core ones that are really indisputable, everybody agrees on: obesity, cardiovascular disease, and diabetes are all metabolic disorders. And it turns out that those three disorders in particular have very significant overlap with mental disorders. So, and the really interesting thing is that they are bidirectional relationships. And that is a unique thing when you're looking at correlations. So when people are trying to understand like what's causing what here, usually we look at epidemiologic studies where we like take a group of patients with schizophrenia and we take a group of patients who are normal, and we like might measure something in them. We might measure levels of inflammation, or we might measure different markers of metabolism. And we see if there's a difference. And so if like the people with schizophrenia have higher levels of inflammation and people who are normal don't have as high levels of inflammation, we then think, well, maybe there's a relationship here. Maybe inflammation is causing schizophrenia, or something's causing the inflammation that's then causing schizophrenia. Like that's how most people think about the science. When we say a bidirectional relationship, what we mean is that the relationship goes both ways. And so it means that if I look at a group of people who have mental disorders, like especially chronic mental disorders, they are much more likely to have diabetes. They're even more likely to have diabetes and insulin resistance before they even get one of my pills that's going to make them diabetic, that's going to make them gain 50 pounds or 75 pounds. Before they even get one of those pills, they already have markers of insulin resistance, and some of them are already pre-diabetic or diabetic. And those statistics are based on people with psychosis. So that includes people with bipolar disorder and schizophrenia, and primarily, but it could include even people with severe depression. And those studies found that people who have an episode of psychosis, so hallucinations or delusions, are 3 times more likely to have insulin resistance, and or diabetes or pre-diabetes. So they're 300% more likely, which is pretty dramatic and significant. So when I look at people with mental disorders, they are much more likely to have insulin resistance and diabetes. But then if I do something different, so talking about this like bi-directional relationship, if I go to a medical hospital and I look at a diabetes clinic, so these are people, they're not supposedly mental, they're diabetics. They're all going to their primary care doctor for their diabetes. If I go into that clinic and I screen them for, hey, any of you guys have mental disorders? Any of you have depression? Any of you have anxiety? Any of you have bipolar disorder? Any of you have schizophrenia? Turns out that the rates in them are dramatically higher. So just looking at depression alone, diabetics are at least twice as likely to have depression compared to people who don't have diabetes. But here's the interesting thing, is that when the diabetics get depressed, it lasts 4 times longer than it does in people who don't have diabetes. So at any given time, about 25% of people with diabetes have clinical depression. And, so they represent a much larger sample. So that 13% of Americans who are taking antidepressants, among diabetics, it's much higher than that. And it depends on what samples you look at, and that becomes a research question about like, well, what are we talking about? Which diabetics, what state, what healthcare system, whatever. So the numbers are different, but what we know is that people with diabetes are much more likely to have depression. And so a lot of people think, well, of course they're depressed. If I had diabetes, I'd be depressed. Sucks
Right.
to have to have diabetes. And yes, it does suck to have diabetes, but actually it's more complicated than that, because if I look at 2 people with diabetes, so let's take 2 people who weigh the same amount, they're both the same age, and one of them is depressed and one of them is not depressed. The person who is depressed is much, much more likely to have out of control blood sugars, to have an elevated hemoglobin A1C, and to develop vascular complications of their diabetes, which is like a whole different thing. So the one with depression is more likely to have their diabetes exacerbated by what most of us think of as a mental disorder, a psychological thing. It's just in their head. It's just the thoughts, those negative thoughts that they're having in their head, and they can snap out of that. Those negative thoughts in their head are actually causing their blood sugar to go up. They're actually causing their blood vessels to get damaged. And if I look at somebody with diabetes who's not depressed, and I follow them for 2 years, and then, a year and a half into it, they develop major depression, their blood sugars go out of control just from the major depression. And everybody thinks that when people get depressed, they stop taking care of themselves. They're not checking their blood sugars like they're not doing what they should. That's why it's not that. The depression is a physical illness. It is clearly affecting their brain, and that's why we hear people talk about sadness and sleep disturbances and low energy and everything else. But it's a physical illness affecting their entire body. And, a lot of people know about this relationship with inflammation, for instance. So we know that inflammation actually makes everything worse. Inflammation makes mental disorders worse. Inflammation also makes diabetes worse. Well, guess what? On those other metabolic disorders that I described, inflammation also makes cardiovascular disease a lot worse, and inflammation also makes obesity worse. And so I won't go through the statistics on cardiovascular disease and diabetes, but it's the same deal, that they also have bidirectional relationships with mental disorders. And so when I've been, talking with researchers and scouring the literature, it turns out that we have a ton of evidence. And let me just say, this is not new. this is not cutting edge. I'm sorry. I'm not being cutting edge right now. I'm telling you a really old story. The old story is that we have known since the 1960s that mental disorders involve disturbances in metabolism. That we have known for decades that lactate levels are higher. Most people think of lactate as like, that's an exercise thing, right? So, you know, when somebody runs a marathon, they have high levels of lactate, and any of your bodybuilders in your audience will know, you know, when you really work out hard, when you really pump hard, you know, that lactate builds up and it makes your muscles sore the next morning. And those are all true. Yeah, lactate does that. Lactate is from, but lactate is produced when we have a metabolic kind of problem. So the bodybuilders and the marathon runners end up having a metabolic problem because they're pushing themselves. They're pushing themselves to the max. They're pushing their metabolism to the max. They're giving it everything they've got, and even a little like slight, you can't really give yourself more than everything you got, but they're approaching everything you've got. And when you get to that everything you've got, our body starts, instead of using oxygen to help produce energy, it starts doing it anaerobically is what it's called. It's like fermentation.
Exactly.
These are all big things. Don't worry about the biology of it.
No, I think that people in the audience will appreciate it. We can talk about this, that if you use the Krebs cycle in the mitochondria, you'll use oxygen and you'll do aerobic respiration. But if you don't use the Krebs cycle and you do, anaerobic fermentation, you'll produce lactate. So
yes,
essentially higher levels of lactate are kind of signaling mitochondrial dysfunction, which is synonymous in some ways with metabolic dysfunction, right?
Yes.
Yeah.
It is. It is. It's at least signaling that the cell isn't producing enough energy, that the cell's energy reserves are stretched thin. And so the lactate story, that's been around since the 60s. And it's really interesting because we know that lactate somehow plays a role in at least some mental disorders. So we have all of these studies from the 1980s and 90s in people with panic disorder. So these are people who, out of the blue, for no reason at all, just develop all these panic symptoms. Their heart starts racing. They feel like they're dying. They feel like they're suffocating. They get all sweaty. And for some people, it can be a debilitating disorder. Some people are terrified that this is going to happen out in public and that something bad's going to happen. They're going to die or whatever. And so some people actually stop leaving their home because of panic disorder. But anyway, if we take a group of people with panic disorder and we put a IV catheter in their arm, if we put basically salt water in their arm, it's called normal saline for the medical people. If we put normal saline in their arm, nothing happens. They're perfectly fine. They're perfectly normal. If we infuse lactate in their arm, within seconds, they're having a panic attack. And this has been shown and proven in double-blind studies several decades ago. The problem is nobody knew what the hell to do with it. Okay, well, we could make people have so I mean, some people actually started telling people with panic disorder, don't exercise. Don't exercise. That's going to increase your lactate and you're going to panic. Now based on everything I know, we could get into it if you really want to, but I would say that's a horrible recommendation.
Yes.
And
yes.
I think exercise is really important. And
right.
Even though it comes with a little bit of lactate, it's good. But so we've known about that, but over the last several decades, we have accumulating evidence for other types of metabolic dysfunction. So you mentioned mitochondria. So those are quote unquote the powerhouses of the cell, and they make energy. And so we know that they show signs of impairment in a lot of different people with different mental disorders. But we also know that levels of ATP are reduced. There are these molecules called, NAD and NADH, which are markers of metabolism. And those ratios are really important. And we can now measure those ratios in the brain cells of people using these really complex scans. These are not available clinically. I'll put that out there. Like, so everybody who's like, oh, let me go get a scan, like, the scan's not going to do anything for you, because at the end of the day, it's still a clinical diagnosis. So either you've got the disorder, you've got symptoms, or you don't. But we've done all of these studies, and we know that people with mental disorders on average have all of these dysregulated, abnormal markers, or they're at least slightly different than normal controls. The challenge is that there's such a broad range of these metrics in everyone, that they don't separate well enough from the normal people. So the normal people might have on average a level of 10, and the people with schizophrenia might on average have a level of 8, but there's a whole range. Like, everybody doesn't have 8 and everybody doesn't have 10. So some of the people in the normal control group might go as low as 6 all the way up to 16 with an average of 10. And then the other group might go like a 2 all the way up to a 13. But there's so much overlap between that. So if you score a 12, we don't really know. Are you normal? Are you not? Like, that's not enough information for us. It's enough information to tell us that there appear to be metabolic abnormalities in people with psychiatric disorders. You know, one of the big things is, you know, we know about inflammation and levels of inflammation. Part of metabolism is the production of these things called reactive oxygen species. So these are, you know, the easiest way I like to tell people is, think about it like a little bit of acid that spills out from a factory. Like, if you go to a power plant or something, like, there's a little bit of waste product that, you know, gets spilled out every now and then that leaks out. And some people think of that as what reactive oxygen species are. They're actually a lot more complicated than that. They end up playing a vital role in our cells. They're a signaling molecule. They do all sorts of stuff. But most people, even researchers, still think of them as bad and waste products.
Exactly.
It's not quite so simple.
No, it's not.
But they stimulate inflammation. And we know that when those levels are high, they stimulate inflammation. And we know that people with mental disorders have more of those, higher levels of both reactive oxygen species and inflammatory markers. And then there's this whole issue of the gut microbiome. And so, like, we're now learning and understanding that all of these bacteria and viruses and fungi and everything else in our guts, like, they eat the food that we eat, and they actually secrete all sorts of stuff. They secrete neurotransmitters, like hardcore, real, legitimate neurotransmitters that go to our brains and affect our brains. But they secrete hormones. They secrete all of these things. Some of the things we don't even know what they do. We know, like, oh, they're secreting this molecule that we'll call X259, but who the hell knows what X259 is doing to the human body or doing to other bacteria? Like, we don't know, but they're secreting something. So there's tons of research going on in this. But we know that the gut microbiome, interestingly, plays a role in mental disorders. So we have decent evidence for that. We have much stronger evidence that the gut microbiome plays a role in obesity, in diabetes, and in cardiovascular disease. We have very strong evidence that the gut microbiome plays a role in all three of those. Do you notice some similarities about, like, what I just, those three metabolic disorders that I just described? We know that the gut microbiome plays a role in those, and we know that it also plays a role in mental disorders. And so how they're all tied together, how they all connect, that's like the multi-billion-dollar question right now that everybody's scrounging for to answer, and everybody's trying to connect the dots and figure it out. To date, a lot of people have attempted to put forth theories. Not one theory has been accepted by mainstream medicine yet. So, so that's, a challenge, a task. It's one that I'll disclose. I can't tell you what I'm working on. I'm working on it. I'm working on that multi-billion-dollar question. Not because I think I'm going to get rich or even make a dime off of it, but because I would love to help human beings who are suffering. And if that kind of knowledge could be helpful to solving some of the bigger problems, that would be awesome. But so, metabolism, mental disorders, metabolic disorders, they're a complicated mess. They really are a complicated mess. And people have been working on this for decades. Nobody's got it all figured out, not even me. But this much I'm fairly certain of. They are interconnected. They are interconnected. And why do I say that? Because of everything I've just been talking about. We have plain as day, clear, simple, easy to understand clinical data. And that means I can look at a group of 10,000 diabetics and see that they have dramatically higher rates of mental disorders. I can look at 10,000 people with mental disorders and see that they have dramatically higher rates of diabetes. Until proven otherwise, when you see a bidirectional relationship like that, you have to assume they are somehow connected. I think most researchers, at least researchers, clinicians maybe not, but most researchers in this space, they already know that. That's not groundbreaking. I'm not revealing anything that a lot of people don't already know. They already know that. We also know, again, bidirectional relationships, heart attacks, strokes, mental disorders. We know that they go back and forth with each other. Obesity and we know they go back and forth. Even our treatments affect metabolism. So the treatments that actually do work for some people, they end up making people fat and diabetic and give them heart attacks. Like, what the hell's with that? Like, how is it that our treatments are all also linked in these intricate, clear ways with metabolism? Why would a psychiatric treatment affect metabolism so profoundly?
Well, certainly, I mean, I asked that question in residency, and we know that the antipsychotics cause mitochondrial dysfunction. That to me is the node, right?
It's interesting because the challenge with that is that the antipsychotics work for some people. So why would they work for some people if they're making mitochondrial dysfunction worse? If mitochondrial dysfunction is the cause of mental disorders, and then I give people a treatment that makes that cause even worse, why would they work in anyone?
Well, I kind of feel like I'm back in residency and you're pimping me. I love it, right? From my perspective, both of those could be true because they're doing multiple things, right? So I think that the antipsychotics and the antidepressants we know are going to affect neurotransmitters. And if the proximate event or if the downstream event in schizophrenia that's causing psychosis is an imbalance in dopamine, which is an oversimplification, but we know that can happen, and you give a medication that's going to affect dopaminergic signaling in some way, I think it's possible with psychiatric medications to improve psychiatric symptoms by affecting neurotransmitters and simultaneously worsen the root cause by causing metabolic mitochondrial dysfunction. So I don't think they're treating the root cause. I think they could improve the symptoms, but I think that the reason, in my opinion, the reason the antipsychotics are causing all of these problems, we know that antipsychotics cause diabetes, and I know that the antipsychotics have been documented to be mitochondrial disruptors. And so to me, that's the simplest common thread. And throughout the whole thing, I think what you're describing there so eloquently, the theme that I keep hearing and the theme that I keep seeing in my own research is mitochondrial dysfunction is at the center of it. But one of the parts of this equation that gets me every time is that nobody really has a good explanation for what mitochondrial dysfunction is. So I want to try and clarify for people. I'd be curious to hear your perspective on this too. But I think that in the previous podcasts I've done, I've made an effort to explain to people what inflammation is, because I don't think anybody actually defines inflammation well. In my opinion, inflammation is just overactivation of the immune system. And then you see all these cytokines. It's a cytokine milieu, a cytokine soup. It's the immune system going, we're on high alert. That's inflammation. Now, what is mitochondrial dysfunction? In my opinion, in my estimation of the science, is that mitochondrial dysfunction is what happens in the mitochondria in response to inflammation. It's when the mitochondria, because the mitochondria are receiving signals too, and the mitochondria, I think, can cause inflammation by the reactive oxygen species, as you suggested. So many people in common parlance suggest that reactive oxygen species and oxidative stress is a bad thing. And for many people, too much of it is. But as you suggested, these reactive oxygen species are used critically for signaling in the human body. And so we can't get rid of them completely. And so I think it's just so silly to me when people are taking boatloads of antioxidants, quote unquote, trying to get rid of reactive oxygen species. And when people are doing things like true sea water, this hydrogenated water, and just really messing with redox balance in their bodies, I'm thinking that is the wrong idea. The real question is, where is the inflammation coming from? And I think my opinion, and I'll be curious to hear yours, is that the mitochondria are generating the inflammation. The mitochondria are generating reactive oxygen species. The mitochondria are generating signaling molecules in these reactive oxygen species that can then cause the immune system to go haywire, and vice versa. The immune system cytokines can affect the mitochondria negatively, but it's this delicate interplay between the immune system and the mitochondria, and then you get this inflammatory phenotype. And so then if you pull back one more, you think, what is causing mitochondrial dysfunction? What is causing all of these things? And then we get to the interesting piece of, in some people, it appears that even just altered glucose metabolism and excess glucose could cause mitochondrial dysfunction. I spoke about that in a podcast I did with Dom D'Agostino. And in some people, it appears that excess glucose can cause reactive oxygen species, can cause oxidative stress, and cause the mitochondria to get dysfunctional. And then the other piece of this that kind of ties it all together is the gut microbiome piece. And I think what's happening for a lot of people is they're getting gut disruption, right? They're getting leaky gut. And this is, of course, like a colloquial term, but I think that my opinion is that many plant foods, many plant antigens are causing disruption of the gut barrier. And then the immune system is getting triggered. It's releasing cytokines, which can then lead to mitochondrial dysfunction. So I think for a lot of people, it's a gut problem. And many of the therapies we're doing can fix the gut as well. And that, in connection with affecting the glucose metabolism through ketogenic diets, I think is where the money is. But what do you think of all that?
No, I think most of what you said, or actually all of what you said, is true. I think all of what you said is true. The challenge is figuring out, again, what's the chicken and what's the egg.
Right.
So for instance, with the antipsychotic medications, we do have evidence that the antipsychotic medications cause mitochondrial dysfunction directly. We have animal models of that, and we've seen hints of it in human data. But we also have clear evidence that the antipsychotics increase levels of insulin and increase levels of glucose within hours of the first dose. And so tying together what you just mentioned about Dom D'Agostino's observation that high levels of glucose can poison mitochondria, is it that, so here's one explanation. And again, this is really complicated stuff. There are thousands of stories, science pathways to tell on this stuff, but I'll tell one of those 1,000 stories. So one of those 1,000 stories is, if you imagine that somebody has insulin resistance. What does insulin resistance mean? It means that glucose has trouble getting into a cell. That's what insulin resistance means. That the insulin, when it goes on the outside of the cell, it is supposed to open up glucose channels that allow glucose to enter the cell, and then that glucose can be used as a fuel source. So mitochondria cells need fuel. They have to have something to burn to make all this ATP that the cells use. So so insulin resistance, some people think about insulin resistance as resulting in a fuel shortage inside the cell, even though there are high levels of glucose right outside the cell. And we have pretty good experimental data to suggest that's true. That seems to be true. That the cells are producing less ATP than they should. They have higher levels of reactive oxygen species, which is a bad sign. So we have some data that glucose is having trouble getting into the cell. And, you know, that alone is confusing to a lot of people. And so the way I talk about it is, you know, there's that old like sailors saying water, water everywhere and not a drop to drink. Well, that's what a diabetic cell is experiencing. It's kind of like glucose everywhere and it can't get in. Glucose is everywhere. People have glucose levels of 300 with diabetes. And I'm here saying, but that glucose isn't getting into the cell where it needs to be so that that cell has fuel. If, you know, one simple way to override glucose, that glucose deficiency or that insulin resistance, the easiest way to override it in the short run is to get a spike of insulin and a spike of glucose. If you spike the insulin and the glucose, that will be enough to overcome insulin resistance in the short run. And then so you've got much higher levels of insulin, you've got much higher levels of glucose. So when those channels do open up, you've got a higher gradient, that it's called. So you've got a ton of glucose outside and it's just pushing as fast as it can through that channel. Whereas if you have lower levels of glucose outside the cell and you have that same level of insulin resistance, you're not going to allow as much glucose to get inside the cell. And so so higher levels of insulin, higher levels of glucose can override insulin resistance in the short run. So what are the 2 or 3 clear ways that we can do that on a practical everyday level? Well, one, most diabetics know this. If you're feeling weak, if you're feeling crappy, go eat a lot of sugar. And that's what they do. They go and binge on junk food that's high in sugar. Why do they do that? Why is it so hard to stop them from doing that? Because they know this works. They just know I feel better. I felt so irritable and cranky and hungry and hangry and everything. I felt like shit. And then when I sat down and had my high carbohydrate snack or my high carbohydrate meal or whatever, I feel okay now. I'm feeling good.
Because they got a spike of insulin from the carbohydrates.
Yes,
right?
They got not only a spike of insulin, but a spike of glucose from all those carbohydrates.
Right.
That allowed more glucose to get into their cells. Their cells are happier for the moment. And so the second way you can overcome this is you can inject insulin.
Right.
So medical professionals know this all too well. And that's standard of care right now is let's override this insulin resistance by giving more insulin. So if you give more insulin in the short run, there is no question it works. Glucose levels will come down. The person will feel dramatically better. The person will do better. And you know, if somebody's in a medical crisis with diabetic ketoacidosis, should they get some insulin? They better get some insulin or they're going to be dead. So, so I'm not here to bash insulin, but the problem with administering insulin over and over again, whether you do it through a lot of junk food or whether you do it through injections of insulin, is that over time, your cells actually get used to that, acclimate to it, adapt to it, and your insulin resistance gets even worse. And so you're like going down this never-ending downward spiral where now, because I've been injecting insulin for the last 6 months, I have to go up on the dose. And my blood sugars are creeping up, even though I'm on a higher dose. And so what does that mean? Well, that means more insulin and more insulin and more insulin. And you keep doing more insulin until what? Until your body is failing in multiple fronts, until you've got kidney failure, until you've got liver problems, until you start developing heart failure, until you have a stroke, until your nerves stop working, your brain is not functioning properly anymore. People get more confused with high levels of insulin and blood sugar. People can't think straight. We sometimes think they're developing dementia. In some cases they are, because we know diabetes is a risk factor for developing dementia. So the third way to get this spike in insulin and glucose on our topic back to antipsychotic medications could be antipsychotics. And could that be helpful in the short run? Just like I described with eating junk food or injecting insulin, could be. If it's conceivable that one of the mechanisms of action of antipsychotic medications is in fact to increase insulin and increase glucose, and that we call that a side effect right now, and it clearly is a side effect and it has consequences. The consequences are weight gain and everything else, diabetes, but it's possible that the antipsychotics are actually having their antipsychotic effect by, at least in the short run, delivering more fuel to those cells so that those cells can function more properly. And if those cells are functioning more properly, chemicals might be more balanced.
So now we're talking about neurons. Now we're talking about neurons in the brain, which may have baseline metabolic dysfunction, disordered glucose metabolism. And in the short term, if you can fix that, then maybe that would improve the neurotransmitter balance.
Yes.
Interesting.
So everything that I've just said may sound like wild speculation to some of your listeners. It's actually based on hundreds, if not thousands, of basic science research articles that I can put all of that together in a very clear and coherent scientific way. As I said, that's one of about 1,000 different stories that I could tell in terms of like, how do we understand mental disorders and their connection to metabolic problems? It's complicated, and there are a lot of stories, and no one has all the answers right now. But I think the really exciting direction that we're heading in is thinking about metabolic intervention.
Yes, I love it.
And so if I'm so convinced of this metabolic connection between mental disorders and metabolic disorders, if we do a metabolic intervention, could it possibly help? Well, you know, my work is on the ketogenic diet, and so I'll stay focused on that. There are actually lots of other stories to tell on this. This isn't the only metabolic intervention that's ever been used in psychiatry. Exercise is an obvious one, and we've got tons of data that exercise can be helpful for mental disorders, even serious ones, even ones like schizophrenia. There's a research group in Vermont that's making their hospitalized schizophrenic patients exercise. And not only does it improve general health, like everybody thinks, oh, well, you're just improving their general health. Sure, everybody should exercise. Yeah, it's just one of those standard boilerplate recommendations. Everybody should exercise. No, their psychotic symptoms are not going into remission. I'm going to say that. They're not going into remission with exercise, but they're improving with exercise. They're reducing. It's helping. So I'll say every patient that I have, I push exercise on. I'm like always like, we got to get you exercising one way or another. We got to get you exercising.
Do you guys have a gym at McLean?
We do.
For the patients?
Yes.
Cool.
Yeah. So we have a gym that's specifically for the patients. We have a dedicated trainer there who is this wonderful woman who has done a lot of work in the mental health field and then decided she wanted to take her career in a different direction and became like a yoga instructor, fitness instructor, and now she gets to combine both kind of passions in a way that is helpful to real patients. So I'm doing work on the ketogenic diet, in addition to a lot of other things I'm doing, but the ketogenic diet in psychiatry is kind of this thing that I've taken on and has become a big passion of mine. And it's become a big passion of mine because I've seen it work. I've seen it work firsthand. Like I said, I'm from the Midwest. I like common sense. Like, does it work or doesn't it work? Like, who cares about your wild speculations about neurotransmitters or, inflammation or mitochondria or anything else? Like, who cares about that? Like, show me something that's going to help a suffering human being right here and now. Show me something that's going to make them better. It turns out that I've seen a number of patients now who have dramatically improved. Some of them have gone into complete remission after decades of serious disabling mental illness. They've gone into complete remission, been able to get off all medications, and are kind of living the happy ever after story, which as somebody who's been a psychiatrist for a long time, we don't always get to see that.
It doesn't happen a lot.
We usually don't get to see it. And
no.
We especially don't get to see it in patients with what we call, chronic, lifelong disorders. So the two unequivocally are bipolar disorder and schizophrenia. So those two disorders, pretty much once somebody gets diagnosed with one of those, we basically tell them, you're going to have to take medication the rest of your life. You have a permanent disorder. This is probably not going to go away. Still try to live a life, try to be happy, try to, work, try to volunteer, try to, keep trying, but, you're on medicine for the rest of your life. That's clear. And don't be surprised if you're in and out of hospitals. Don't be surprised if you continue to experience symptoms all the time or most of the time. Like, don't be shocked, because that's par for the course. That we don't know what causes your disorder. And so when you see patients like that have full, complete recoveries, get off all the medicines that we have assumed that at least I personally had assumed are required, because I kind of followed the guidelines. I followed the paradigm. I knew for a long time, this isn't working. Like, this paradigm sucks. I went into psychiatry to help people, and I'm doing my best, but these medicines that I'm giving everybody, they're not doing it. Like, why aren't they better? Why aren't they cured? They should be cured. Like, they're hardworking. I like this one. This one's really nice. This one's hardworking. Like, he deserves to be better, or she deserves a remission, and they don't get it. And
that's been my world for the last 4 years of residency, my man. I get it.
Yeah. So if it's of interest, I'll at least tell one of the stories.
Yes, please do. I think these are so striking.
Good. I mean, I can talk to the bigger picture because a lot of people are like, well, anecdotes don't count for anything. And let me just at least address that in one small way. So, you know, in the medical literature, the levels of evidence that we look at, anecdotes are in fact the bottom of the barrel. And why is that? Because anybody can make up any story. Anybody can say anything. So people, all sorts of people claim, you know, oh, I got this snake oil, like literal snake oil, but it's from a rare Brazilian snake. But it's snake oil, and I took it and I'm all better. All better from what? It doesn't matter. It cured my lupus. It cured my cancer. It cured my schizophrenia. Like, unfortunately, if you look on the internet for even 5 minutes, you can find all sorts of claims from people like that. So sadly, anecdotes don't count for much of anything. Case reports are different. Case reports are usually one case report, and it's different because it means that somebody's taken the time to outline a clear case based on our current medical thinking, and they then describe a series of events that, like, we started a diet and things changed dramatically, and then the patient stopped the diet and things got worse again, and then we restarted the diet and things got better again, and then the patient cheated again and then things got worse again, and then we started the diet again. So I think when medical professionals feel like they've witnessed a case that's actually pretty convincing in that kind of a way, like, there's no other reasonable medical explanation for this recovery. There's no other good reason why this person would be better. Any medical professional can write up case reports and get them published. And there's a peer review process in the publishing part of it. And so there are colleagues and researchers and scientists and, you know, academic people who are reading that, and you have to convince them that, like, no, this is at least worth considering.
Yeah.
Even if I haven't definitively proved it, it's worth considering. You have to convince them. So I've now written up 4 case studies. So when you get more and more of these, it starts becoming more convincing. So I've now written up 4 case studies in a journal called Schizophrenia Research. We have really good animal data on this now. And so animal studies are larger. They include multiple animals. In this case, it's mouse. It's a mouse model of schizophrenia. We have multiple studies, at least 3 studies that are published, and we have many more that are on their way, from a group in Australia, Zoltan Cernaya and Annie Creator. I want to put a plug in for them, but they're doing this research. And that kind of research is important because they can have control groups. So they can give half the mice the ketogenic diet and half the mice a regular diet, and have blind observers kind of observe the mice and see, are they any different from each other? We don't even know which ones are which. We don't know which ones are on the diet or not.
That's the blinding part of the study, that the observers, the raters, don't know.
Yes. So they can blind the studies, and those show results. So we've got several studies now of animal models, ketogenic diet working. We actually have a case series of 10 schizophrenic patients dating all the way back to 1965 of the ketogenic diet for schizophrenia. And they reported that the diet worked for them. But so we've got a fair amount of evidence, but I'm going to tell you one story. And this story is important because most people, including myself, until I came across this woman, I was with most people that schizophrenia is probably a neurodegenerative disorder. We know that the brains of people with schizophrenia age prematurely. We know that parts of their brains are actually shrinking, and that means their brain cells are dying. That means some of their brain is dying through this process. And so a lot of people think of schizophrenia as a neurodegenerative disorder. And even with the inflammation hypothesis, you can think of it like, if all that inflammation's been eaten away at your brain for decades, like, oh, at some point it's going to start rusting beyond repair. Like you can't just wash it and have it all come out all clean. Like at some point that corrosion is going to take in and it's going to actually have an effect, just like rust on a car. Like at some point, it's not the same thing. At some point, you can't just clean it off and it's all going to be good. And that's the way most people thought of schizophrenia. This one patient who's given me permission to use her real name, her name is Doris. She was 70 years old when she started the ketogenic diet. She had been diagnosed with schizophrenia since she was a teenager. She had hallucinations every day. She heard voices. She thought that she saw skeletons in people. She would look at people and feel like she could see a skeleton there, or feel like they were like from the dead, or maybe a zombie or something. She was very paranoid. She was horrifically miserable. In the 2 years prior to starting the diet, she had tried to kill herself at least like 4 or 5 times, was hospitalized for most of those. One of the times, just to give you a flavor of what we're talking about, she drank a bottle of cleaning fluid, hoping that would kill her. She was obese, morbidly obese, from all the drugs we put her on probably, and maybe just, people with schizophrenia, they lack motivation, they sit around a lot, they're afraid to go out, so it's understandable why so many of them are obese. The majority of people with schizophrenia after 20 years are obese. About 2/3 are obese. Not just, and I don't mean overweight, I mean obese, which is like way beyond what we're seeing in the United States population. And she also couldn't take care of herself. So like most people with chronic schizophrenia, she had a guardian appointed by the state, and she had a team of people who came in to help her take care of herself. They would take her grocery shopping, they would pay her bills, they would help her get cleaned. If she hadn't taken a shower in a while, they'd encourage her to take a shower. They did all of those things. So for any of your listeners who've ever dealt with someone with schizophrenia, this is actually the norm. 70-year-old chronic paranoid schizophrenic. She's lucky that she wasn't in a nursing home, because most of them probably would have been. She was not in a nursing home, but she certainly had a tremendous amount of community supports, in-home supports. She had a guardian. She clearly meets everyone's definition of chronic schizophrenic. So she ended up going to a weight loss clinic at Duke, run by Eric Westman. Some of your listeners might be familiar with him. And he's been a big proponent of low carb or ketogenic diets for a long time. And he put her on a ketogenic diet, not to treat her schizophrenia, for God's sakes. Like he's just trying to help her lose a little weight. At the time, that 1965 article was like just in the dust. That was lost to the archives of research. Nobody knew about that. Nobody talked about that. All of this metabolic research, nobody knew what to do with it. Like how do we make sense of it? What are we going to do? So he was just trying to help her lose weight. Within a couple of weeks, not only was she losing weight, but she started reporting that her hallucinations were going away. Within, I think, about 6 months, she took it upon herself. She didn't get approval for this. I like that in her. But don't do this at home, because it can turn into a nightmare. And I've seen it happen. I've seen it be a nightmare. So I don't mean to support her in that way, but I support her spunk. But she took it upon herself to get herself off all her meds. And And she was symptom free at that point.
After how many weeks?
Her hallucinations and delusions were completely gone.
After how long?
After, there are conflicting reports. The original report said after 8 days that her symptoms were almost absent. When I spoke with her, that wasn't clear to me that it was that fast. So I think it's safe to say that within 2 months, at least for her, her symptoms were completely better. I can tell you from my own clinical experience, it takes longer than that for a lot of people, and the symptoms just don't completely go away. And I'll speak to that in a bit, but I'll finish her story. So her story is compelling and important because it's now 12 years later.
That's amazing.
We don't have to wait for like what happens to Doris, what's going to happen to her. It is now 12 years later. Doris is alive and well. She is off all psychiatric medications. She has lost 150 pounds. She no longer has a guardian. She no longer has a team of people coming to her apartment to help her clean, to take her grocery shopping. She does all that for herself because she is now in remission from her schizophrenia. She is in full remission. She still does a low carb ketogenic diet. And so I cannot use the word cured because a cure would be you don't have to do a treatment anymore. And I consider the ketogenic diet a treatment. And if you still have to do a treatment to stay in remission, then by most people's definitions, that's not a cure, but it's certainly a remission, a full, complete, unequivocal remission. And when I spoke with her, so she's a very religious person, and she attributes a lot of this to God. But when I spoke with her, she's happy. She's like happy to be alive. She's just like, I feel like I've been blessed. Like God has shown mercy on me. Finally, after decades, God has shown mercy on me and relieved my suffering. And, and she's like, wants to spread the word. She's like, if my story can help even one person, please tell it. Please tell my story. Because what I've experienced is nothing less than a completely new life. And for anybody who's done work in the psychotic disorders space and worked with people with chronic schizophrenia, I mean, the symptoms definitely can wax and wane. And what that means is they can come and go. Sometimes they're really bad. Sometimes they're not so bad. But remissions like this, especially after 60 years of symptoms, or 50, I guess precisely with her, it was 53 years of symptoms with her. After 53 years of being diagnosed with schizophrenia, having a guardian, having home health services, being morbidly obese, these transformations do not happen. Even with the best of medications, even when we get new drugs that come out, like even with ECT, even like any of our treatments, no matter how aggressive they are, they do not do this. And so I think that her story is important. Again, her story is not an anecdote. Her story is not alone. There are a lot of other people who've had similar stories to hers. And, I published 4 of these stories in Schizophrenia Research. I want to point out, not everybody gets a complete remission. Some people don't go into a complete remission. Some people get improvement in symptoms.
Those people need the carnivore diet, my man.
Maybe I'm open to lots of ideas. I'm open to, but at the end of the day, I want to see what works. Like, show me the money,
right.
Show me the money. Let's see what actually works for real human beings with real disorders. but not everybody gets a full remission.
And so I just want to clarify for the listener, at Eric Westman's clinic, in your clinic at McLean, how do you construct a ketogenic diet? Because I just want people to be very clear on how ketogenic these diets are, because keto diets have become sort of colloquial. And I just want people to really understand what sort of therapeutic modality we're talking about here.
So it's widely variable across different treaters and across different universities or centers. So I am by and large using the medical version of the ketogenic diet. So when Eric Westman put this particular patient on her diet, he was doing the weight loss version of the diet. It was basically the Atkins diet with a lot of fat. She lost 150 pounds. There's no question that she was ketogenic for most of that. And when somebody's morbidly obese, it's actually pretty easy for them to get into high levels of ketosis because they have so much fat on their body to lose. As people are thinner, like as people lose that weight, and or if somebody comes to you already thin, it actually is more challenging to get them in a high level of ketosis because they don't have as much fat on their body to tap into. So I've been using the medical version of the ketogenic diet, which follows the epilepsy version of this diet. And so I usually use at a minimum a 2-to-1 ratio of fat to carbohydrate and protein, and sometimes go all the way up to a 4-to-1 ratio diet. It's interesting because in the epilepsy literature.
And how much carbohydrate are you putting in the diet? Because this is very variable.
So I always do less than 20 grams.
Okay. So basically you're pretty much doing 2-to-1 fat to protein, right? Which is actually the ratio that I would recommend for a carnivore diet for people as well. And then you're having less than 20 grams of carbohydrates, so a small amount of carbohydrates.
Yes.
Okay, perfect.
Yeah.
All right.
Tiny.
Yeah.
And whether people eat carbohydrates or not, I like some people will say, like, do I have to eat? And like, no, you don't. Like, eat 0 carbs if that's what you want to do. If you want to go more carnivore and just eat primarily meat and some dairy, some, kind of cheeses or other things, butter, if you want to go with that, that's fine. At the end of the day, a lot of them will use MCT oil, which is based on coconut oil. So that's coming from a plant source. So, I mean, there are, different things, but,
Yeah.
one of the common sense things. So a lot of people are really skeptical about all of this, and they hear, schizophrenia, a diet for schizophrenia, that's like crazy talk. That's crazy talk. Like, there's no way, especially psychiatrists who've treated this disorder for decades, and patients and families who have had this disorder, who've dealt with this disorder for decades. To them, changing diet, changing this illness is like incomprehensible. There's no way a diet, this is like a brain disorder. This is like a hardcore, it's pretty much as bad as a seizure. Like, when I see somebody seizing on the ground, I know they have a real disorder. They've got a brain problem over there. And schizophrenia is like that. Well, I use that comparison because guess what? This diet can actually stop people's seizures.
Right.
And and it doesn't mean that a bad diet caused their seizures. And I'm not here to say that a bad diet is the cause of schizophrenia. I mean, we don't have good data that it is.
Sure, we just don't know.
We don't know for sure what causes schizophrenia. Could diet contribute to it? Absolutely, especially if we're going to talk about gut microbiome, because we know whatever we're eating is affecting our gut microbiome. So if gut microbiome plays any kind of a role, well, then maybe what we're eating is somehow affecting it. But the reality is that even though we don't know what causes schizophrenia, for instance, just like we don't know what causes epilepsy, it doesn't mean that a dietary intervention can't work. And it doesn't mean that a dietary intervention is less than or is kind of a quote unquote light treatment. This is a hardcore, like this is a hardcore metabolic shift, change, disruption in the human body. And when people first start this diet, they know, they feel it. They usually feel like shit. I mean, a lot of people call it keto flu or keto adaptation or whatever. People feel like shit. And one of the warnings that I have about that is that that period of keto adaptation or keto flu can actually make psychiatric symptoms worse before they get better. So, you know, normal people just trying to lose weight will say, I felt like shit for that first week or two, but then everything cleared and now I feel great. And this is the easiest diet. I love this diet. It's great. But in people with serious mental disorders, you have to get them through that period safely. And they might get even more depressed. They might even get more psychotic. They might get suicidal. You know, and so you have to, that's the primary reason I'm really concerned about people trying this on their own. If you're dealing with a really serious mental disorder like that, you like deserve help. You deserve like a competent medical professional, a psychiatrist, a nurse practitioner, psychologist, somebody. You deserve somebody who knows what the hell they're doing, who knows about your disorder, who knows how to keep you alive in a bad situation. And so, yeah, but at the end of the day, this diet works. It stops seizures. I'm exploring more and more evidence that it's helpful with serious chronic mental disorders. And for any of your listeners who aren't familiar with the field of psychiatry, this isn't a far stretch. So every anti-epileptic treatment that we know is used in psychiatry. So every anti-epileptic medication, things like Depakote, Tegretol, Lamictal, Topamax, Neurontin or gabapentin, Klonopin, Valium, Xanax, you've all heard of those. Well, those are all anti-seizure medicines, but we use them like candy in the psychiatric field. They are the bread and butter of what we are giving patients with mental disorders. And for some people, they help. They definitely help. They stop their symptoms. They alleviate their suffering. They get them better. And so these treatments actually, in fact, work for some people. They don't work for everyone, as we've discussed, but they do work. And so this diet has been proven in every imaginable way we can think of. This diet has pretty much been proven to stop seizures. And so if every other treatment for epilepsy is also used in psychiatry, it's really not a far stretch at all to think, well, if this diet stops seizures and the neurologists, like legitimate neurologists, are using it for legitimate neurological disorders like epilepsy, maybe we should be using it for like legitimate psychiatric disorders, just like we currently use Depakote, Neurontin, Valium, all those other things for all the disorders and symptoms we're treating.
Absolutely. I couldn't agree more. And you follow a ketogenic diet a lot of the time too, right?
I do. So I would say low carb, at a minimum low carb, and sometimes it's ketogenic. I've done the 4-to-1 ratio ketogenic diet, not because I thought it was healthy for me to do, but because when I started prescribing it to patients, I wanted to make sure I knew what I was getting them into. And I wanted to make sure I understood, like, how hard is it to like get these ketone levels way up? How hard is it to get in all of this fat and this oil and everything else that you have to get in? So I've done the 4-to-1 ratio ketogenic diet. I can do it. I don't think the 4-to-1 ratio ketogenic diet is the health diet for everybody in the population to do. I really don't.
It's
I think it,
pretty low in protein.
yes, it's low in protein. I think that it's a medical intervention. It's a medical treatment. And for people who have tried a lot of other things and they're not working for them, this diet can stop seizures and can do all sorts of other things. So I myself went on a low carb or ketogenic diet. I've been on one for over 20 years now. And I've been prescribing this diet. So the mood benefits have been pretty clear to me. Like, I became a different person when I started this diet, when I went on this diet. I went on it because I was having my own metabolic problems. My blood pressure was going up. My bad cholesterol was going up. My good cholesterol was down. My triglycerides were high.
Sounds like metabolic syndrome.
I was developing metabolic syndrome in my late 20s. And so in hindsight, I can tell you why. It wasn't because I was fat. I actually was one of those skinny people with a little bit of a gut. But I was doing a very ultra low fat diet. Why was I doing a low fat diet? Because that's what everybody was telling me I was supposed to do to be healthy. Like, the medical community was saying, all fat is bad. Don't you dare eat nuts. At that point in time, olive oil was evil. Every fat was bad. We knew it with certainty that certainly the medical people issuing the guidelines, they issued the guidelines as though they knew it with certainty that all fat is bad for you. Like, don't eat that olive oil. Don't put butter on anything. No fats at all. Like, fat is toxic. Fat is evil. Fat makes you fat.
Clearly.
And, so I, being a good medical student, medical resident, I, followed that advice. I wanted to be healthy. I didn't want to end up like all these diabetics that I was seeing in my clinic. And unfortunately, that was awful for me. It was toxic to my body. And I ended up finding my way to a low carbohydrate ketogenic diet, really more in an act of desperation. I was kind of like, oh, it's come down to, like, I'm going to have to go on pills. And, like, this is my one last desperate shot to, like, I'm just going to do this stupid Atkins diet thing. And I'm going to go on that and see what happens. And it worked. My blood pressure improved within 3 months. My cholesterol levels, my triglyceride, everything got dramatically better within 3 months.
Imagine that.
But I noticed, yeah, no, I know. But I definitely noticed improvement in my mood, in my energy, in my motivation. Life was easier. Life was just a lot easier. Sleep was better. Everything was getting easier. And so even at that point, I had the thought, like, I wonder if this could help people with depression. I wasn't clinically depressed at the time, but I was like, it seems like this might be helpful to some people with depression. So probably 15 years ago, I started using this diet, not the 4-to-1 ratio epilepsy version of the diet, but I started using basically low carbohydrate or ketogenic diets with people with chronic depression. And I'd had some actually really good success stories. At that point, it was still highly controversial. It still is to this day. But
who knows why? I don't know. We're going to change the world, man. We're going to change the world.
The world needs changing. That's
yes,
for sure.
It does. Yes, it does.
So back then I was, I didn't want to necessarily go out on a limb and, like, put my career in jeopardy or anything like that. So I didn't. I didn't really talk about it too much. I was just using it clinically for those people who tried everything else and nothing was working for them. I was certainly using it with people who wanted to lose weight. I was kind of like, well, don't waste your time with a low fat diet. Like, I can't in good conscience do that to you. And I'd talked to people who tried so many other diets and, they just hadn't worked. And I've coached hundreds of people on how to lose weight with this diet. both patients, but also friends, family, random acquaintances. I mean, I'm just like kind of everybody knows me as like, oh, Chris Palmer, the low carb keto guy. And that's fine. That's good. The I think what happened 3.5 years ago with one of the patients that I was treating with schizophrenia, he went on the diet, and I ended up getting him. We needed to go to more of the epilepsy version of a ketogenic diet, and he had dramatic improvement. And that was kind of the turning point for me. I was like, I can't stay quiet about this anymore. This is too important. Like too many human beings are suffering.
Right.
Too many lives are ruined. Too many lives are lost to suicide, to premature death. It's it's unconscionable. Um, and and I don't mean that the psychiatrists delivering this care are unconscionable. I want to like be clear.
Yes.
What's happening to these people's lives is unconscionable, but the people doing this work are doing their best, and
Yep.
I want to put a plug in for them. They really are. They care about these people. They went on a limb to even go into the mental health field to begin with, because the mental health field is highly stigmatized, as you probably know, having chosen psychiatry, not too long ago, 5 years ago or whatever, when you were making your decision. You go to any medical school or like everybody tries to talk you out of psychiatry. Like, don't do that field. That field sucks. Those people are all quacks. They don't, and the biggest reason I think that we have so much stigma in the medical community is because they look at the outcomes of our patients and they're like, you don't do shit. Like, you just make your patients fat and sedated, and you're not helping people. You're not delivering decent care. You're not improving people's lives. Why would you want to go into that field? Like, I want to be a surgeon because I want to take people who like have a bad accident or their life is on the line, and I'm gonna fix them up and they're gonna have a good life again. I want to be a primary care doc because I want to keep people healthy and happy through their ups and downs in life, through all of their medical problems. I want to be an OBGYN because I want to bring new life into the world in a happy, safe, healthy way. And I think a lot of those medical professionals look at psychiatry as, we're just the head shrinkers. We're the people who are just making zombies out of our patients. And we make a bad situation a little better. Again, we keep them out of jail. We calm agitation. If somebody's getting assaultive and violent, we can call. We've got pills for that. We've got injections for that. We can manage. And I don't mean to sound so sarcastic with that, because if somebody's really violent, I'll be the first to like be there with an injection and stop them. Like they can't be allowed to be violent. They can't be allowed to like kill people, maim people. They can't be allowed to like mutilate themselves. Like, somebody needs to do something. So I I hate that that's where we are as a field. But on that front, I know with certainty I'm not alone. Almost every other psychiatrist feels the same way. Almost every other psychiatrist is like, yeah, give me something. Give me a pill. Give me a treatment. Give me anything. Give me a diet. I don't care. Give me something that really works, that really legitimately works. Because I do want to help my patients. I do want to get them better. And unfortunately, there are tons of charlatans and snake oil salesmen and quacks out there. They've been out there since time began. They're saying, I've got some snake oil for you. They're saying, I got this supplement that's going to cure everyone. They're saying that I've got this vitamin that's going to cure everyone. And that's the challenge. That's the challenge with where I feel like I'm at right now. Is right now I feel like I, and probably you, are lumped in with them. That we're just part of that whole cascade of characters that we've all heard from decades and centuries of just, you've got a product, you don't care that it doesn't really work, you're just trying to make a buck. Well, the first thing I'm going to let everyone know, I'm not making a penny off of this. I'm actually losing money. I'm turning patients away because I'm trying to free up time to do this research for which I'm getting paid $0. I'm volunteering my time to do this research, to do a lot of the writing that I'm doing, the case reports. You get something published in a medical journal. In case any of you naive listeners think I get paid a dime for that, like, it's an honor and a privilege to get anything published in a medical journal. That's all free work. Like, you do all this work and you get it published, and it really is an honor and a privilege, but you don't make any money off of that. So I can tell you, at least, I'm not a charlatan, because charlatans make money off of what they're doing. they have to make.
You know what else? Ketogenic and carnivore diets work. And you've seen this and I've seen this. And that is why I got onto this path. And I would, carnivore diets should be ketogenic in my opinion. Most of the time they are. But these interventions work. We didn't have time today to talk about elimination diets, but we know that food is the biggest lever that we can pull. And understanding the way that food creates disease and health is the greatest, I think, paradigm shift that will happen in medicine in the next 20 years. And when mainstream medicine wakes up to this, you and I will hopefully be at the forefront of leading this charge. And I think that, when I was in medical school, psychiatry was maligned. Psychiatry was not talked well of. But I think that is crazy, especially when, as you highlighted, depression is the #1 disease in terms of loss of productivity. It's the #1 cause of morbidity in the world. So how anyone can look down on psychiatry is crazy, because we are badly needed. But I am so excited about this movement, because what you are doing and what I am trying to do, I think, is changing this paradigm and giving people interventions that actually work and that address the root cause.
Yes, I'm 100% with you. And I think, I do think the time is right. I think this is we have the potential to make this our decade for a major paradigm shift in the mental health field. We have the opportunity, because we've got more than enough basic science data. So we don't need more basic science data to kind of see some of this. We have a lot of evidence based on the gut microbiome. And again, a dietary intervention affects the gut microbiome. And I think most people in the medical field take the gut microbiome very seriously. That evidence is pretty compelling, and millions and millions of dollars are being spent on that research. So I think people take that very seriously. I think the challenge is now on us to show that our interventions, in fact, really do work. There's actually a few challenges. So one is to show that our interventions work in real people with real symptoms. The other challenge is to show that we can get people to do the intervention.
Yeah.
So there was this study, there's a lot of interest in the ketogenic diet for Alzheimer's disease prevention and or to slow the progression of Alzheimer's disease. Johns Hopkins just did a 2.5-year study trying to recruit. Their goal was to recruit 60 patients. It was a randomized controlled trial. They had half the group doing the ketogenic diet and half the group was going to do this kind of healthy diet recommended by a geriatric society or something. It was probably the equivalent of the American Heart Association diet. And so that's a great design. Like, let's randomize the people. Like, everybody's coming. They'll do whatever we ask. Half of you're going to do the American Heart Association guideline diet, and the other half, you're going to do this ketogenic diet. And we're going to see once and for all, is there any difference between the two groups? And those researchers tried and tried and tried. And at the end of the day, they screened over 1,000 people And I think they had 14 people complete the study.
Oh, man.
14 is all they could get. And even among them, a lot of them weren't super compliant with the diet. Based on the evidence that they did acquire, they found that for those people who had even trace levels of ketone production, they had improvement in their cognition and improvement in mood and energy. The improvement in cognition is significant because not one medication trial with Alzheimer's disease has ever shown improvement in cognition. And this was in just 6 weeks. In just 6 weeks, they found a statistically significant difference in cognition, an improvement in cognition in people with Alzheimer's disease who could be on a ketogenic diet. I'm not talking the 4-to-1 ratio diet because they weren't doing that. So part of the challenge, the researchers doing that research they run epilepsy centers using the ketogenic diet. Their heart and soul is in this. They know this stuff like the back of their hand. They had presumably some of their best educators, some of their best dietitians on this study. And they couldn't persuade these elderly people to do the diet and stick with it. And so I think part of that's one of the other challenges of doing dietary research is how do we get people to do it and what do we need to do? So, we in psychiatry, and this is where I think people like you and me have an advantage. So those are neurologists. Neurologists on average see patients most frequently once every 3 months or something.
Right.
They see them for quick visits. Neurologists are not trained or skilled in behavior modification, motivational enhancement, like, let's change your behavior. This is going to be hard. This is going to be tough, but you're going to be able to do this. They're not skilled in those things. We in psychiatry, we try to talk alcoholics out of drinking alcohol. We try to get people who have binge eating disorder to stop binge eating. We try to talk anorexics to eat a little more, stop starving yourself. Please stop starving yourself. And those are all difficult behaviors to change. And yet that's kind of our sweet spot. That's what we do. We help people change behaviors. And diet is a hard change. And I think that's one of the tools that we might be able to bring not only to the mental health field, but if the ketogenic diet has applications, we know it has applications in epilepsy, but a lot of adults with epilepsy can't get themselves to do this diet. We know this diet has applications potentially with Alzheimer's disease, yet, people are struggling to get them to do this diet. And so I think we can bring our skill sets to the table to really help motivate people to do this diet, make it easier to do. I mean, there are a lot of models we can consider. I mean, I'm working with some vendors to actually provide the food for one of the research studies I'm working on right now. So we're literally gonna not quite literal, but we're pretty much gonna spoon feed them. We're gonna give them every meal and snack shake, everything they need, so that they don't have to think about it. They don't have to do any research. They don't have to lift a finger. All they have to do is just eat what we give them and share their criticisms with us. If they don't like something, okay, we won't bring that again. We'll bring you something else that you like.
Right.
We're going to work our butts off. We're going to work our butts off to make this diet doable for you, to make this diet easy to do.
And I think that I agree with you completely. I think within psychiatry, we are uniquely trained to help people understand how to make behavioral change. And I always bristle at criticisms of things that are based on compliance, because I think that that's sort of putting the cart before the horse and saying people won't do it. It's like, well, look, we need to prove how valuable this is and then provide it as an option, and then people that want it will find it. in my work, I'm not convincing anyone to do a carnivore diet. People find me because they want to do a carnivore diet. And I think those are the people in which we should be studying the most. Like, because, at Hopkins, they're trying to recruit people to do a ketogenic diet. But look, there are thousands of people that will want to try a ketogenic or a ketogenic carnivore diet when they understand how valuable these interventions are. And those people will be meaningful lives saved and altered in a positive direction. And so I think that it's important to say, I don't listen to the critics who say the compliance will be a problem, because I know there are people that want to get well. And when like you said, in the people that are already willing to make the change, these interventions are incredibly valuable. I'm not about convincing someone to do anything they don't want to do, but I think that we need to study the interventions that can be valuable for those that are already motivated. So I am super excited. I'm super excited for somebody to do a carnivore diet at McLean. You'll have to let me know. We gotta do a pilot study of the carnivore diet at McLean. I mean, we could do a ketogenic carnivore version, but how cool would that be?
That would be very good. So doing this research is hard because, funding is hard to come by and all that stuff. On the carnivore front, I would push you.
Yes.
Either you alone or you and Sean Baker or you and others to write up some case reports.
Yeah.
And I'm really serious about that. So part of writing case reports, it might seem like a waste of time. Like I said,
they're out there.
You don't get paid a dime for it. But so I don't mean anecdotes on the
No,
web.
there's a group in Hungary, Paleomedicina. I should have sent this to you. They published, I think, 5 or 6 carnivore case reports.
Oh, awesome.
Yeah. There's carnivore case reports, not for psychiatric illness, but for type 1 diabetes, type 2 diabetes. They had a patient, I interviewed Sophia Clemens last week on the podcast. They had a young patient with type 1 diabetes who was able to come off insulin. They had preservation of pancreatic islet cells on a ketogenic carnivore diet. They've done rectal cancer, they've done cervical cancer, they've done ulcerative colitis and Crohn's.
Awesome.
So but yes, I agree. I want to publish some case reports.
So I hadn't seen that, but I think the case reports are an important way to start moving the field forward, because it's it's a political thing, unfortunately. And I've never been a fan of politics, but it is a political thing. And so just like in our political system in the United States, a lot of people sit around and, they're armchair politicians and they bitch and moan about, everything sucks, blah, blah, blah. Well, if you actually really want to change politics in the United States, you can do it, but there's a process.
Right.
So sometimes it's get a petition. Let's just go to the masses and get a petition. Sometimes it's let's get our senator or congressman to introduce a bill and try to get that bill passed. There are a lot of different mechanisms to make political change. In the medical community, for better or worse, the medical literature is like a required path. If we really want to change this and be able to help, because that's part of my goal, is I want to help the hundreds of millions of people out there around planet Earth who I can't treat. I can't take their phone call. I can't respond to their email. I'm one person. It's just me. So I want to convince their providers who are equally desperate, please, somebody develop something that will help me help them. And the only way to truly effectively communicate that to those providers and make it doable so that they can actually do it without losing their license, without getting fired from their job, without whatever, to make it so that their hospital system will actually let them try it, is we have to get stuff published in the medical literature.
Yeah.
And it's a bureaucratic thing. Yeah, it sucks. Yeah, I get it. But I want to be a doer, not a complainer. So I'm trying to do.
Let's do it, man. We're going to do it. So where can people find you and all of your research? Because you have published case reports and you have published a couple of other editorial type pieces about this kind of stuff, where can people find you and your work?
So the easiest place is if they come to my website. So I have a website, chrispalmermd.com. And for people who are interested in doing this intervention, if you are thinking of yourself or a loved one that wants to try a ketogenic diet or carnivore diet or whatever you want to try, if you want to try something for your psychiatric disorder, I have some resources on the website with providers who have, I think we've got you, Paul.
I hope so.
Yes, we've got you listed as well, but we've got providers listed who have said that they are willing and able to help people with mental illness and with this diet. We have some providers who, you know, at a minimum, I basically encourage people to have a competent diet person who knows what they're doing on the diet and a competent mental health professional who knows how to assess for symptoms and manage crises. So somebody who knows if you're in a suicidal crisis, I know what to do. I know what needs to be done, and I'll do it. I will prevent a suicide. And so I think a lot of people are probably going to need a team in order to get those two components. That a lot of mental health professionals aren't comfortable with a ketogenic diet, and they don't know the protocols, and they don't want to learn the protocols. It's a lot of work. It's a lot of information. And so that's fine. They don't have to. If you can convince them that you want to try this in a legitimate way, just like you're trying a medication, and you're going to try it for 3 months and you're going to see how it goes. And you and your mental health professional are going to make a decision together about, like, is this helping me? Is this not helping me? We have dietitians. We have ketogenic dietitians who work with epilepsy patients. I mean, this is what they do. This is their bread and butter. They know this diet like the back of their hand. They're willing to work with patients. And a lot of them will do virtual consults and work with people virtually, so you don't have to go to them. So if you can convince your mental health professional that you want to try this diet, and you can find yourself a ketogenic dietitian, that could be a model of a safe, reasonable model for you to be able to try this today or tomorrow and do it in a safe, controlled way, supervised. And I have so a lot of patients have said they're psychiatrists, they're skeptical, whatever. I've encouraged a lot of them to print out the articles that I've published in schizophrenia research. I publish stuff on Psychology Today that is really written for more of a general public audience. So I try to put things in easier to understand terms. So the stuff that I write in medical journals is written for physicians. So a lot of the stuff is over people's heads. That's okay. But in order to talk to doctors, you have to talk doctor speak.
Yeah.
And so for the lay audience, I write in a different way to try to make it understandable and accessible for them. But a lot of people have just printed out those articles and taken them to their psychiatrists, and their psychiatrists are like, okay, you're like, yeah, no, this makes sense. This is decent evidence. This is
amazing.
This,
I love it.
This is the legit, and this guy's at Harvard. So if he's at Harvard, that's where I use my Harvard thing, and I wear it and I use it because this is an uphill battle. There's no question. This is an uphill battle. So
you better believe after this podcast, I'm going to say Harvard endorses the carnivore diet.
Well, at least Chris Palmer from Harvard. So
I'm joking.
You can go there.
I'm joking.
But,
that's awesome.
But yeah, so chrispalmermd.com, you can find a lot of my stuff. I'm on Psychology Today. So yeah, either place.
Cool. Chris, the last question I always ask my guests is, what is the most radical thing you've done in the last month? Because I love the word radical and I'm a child of the 80s.
The most radical thing that I've done. I wasn't prepared for this question.
Oh, out of left field. I surprised you.
Out in left field. What have I done in the last month? I guess I'll just say, I've started blogging for Psychology Today. This isn't all that radical. So I just published a thing on nutritional psychiatry. And
Cool.
it's broad. It's broader than just keto. It includes keto, and fasting and some other things, but it's broader than that. And so I just published that this morning. And the Psychology Today editors thought it was good enough that they put it as their banner story for the whole Psychology Today thing. So that's kind of radical, I guess, for me.
That's pretty radical. So if people want to read that, they can go to Psychology Today, and all the other stuff's on your website.
Yes.
I am so looking forward to our future collaborations, my friend. It's great to have you on the podcast. Thank you so much for this extended, very detailed conversation, which I'm sure many people will get a lot from.
Yeah, no, thanks, Paul. Thanks for all you're doing and for having me on.
All right, my people. What do you think of that episode? That was a long one, but we covered a lot of cool stuff. And I think this is going to be paradigm shifting in the world of psychiatry and the world of medicine. As I've stated on multiple podcasts in the past, I believe that psychiatric illness is autoimmune and inflammatory. And I believe that ketogenic diets are the beginning of working toward correcting the root cause of that. My personal opinion is that a carnivore diet that is ketogenic is going to be the best option because it's going to remove so many of the potential plant toxins that could create leakiness to the gut, leading to systemic inflammation. But any sort of ketogenic diet appears to be quite beneficial, as Chris is showing. And as I talked about in the podcast, I am certainly hoping that we will get a carnivore keto study at McLean Hospital at Harvard, which would be fantastic. And as I joked about in the podcast, Harvard is supporting the carnivore diet, you guys. It's amazing. So anyway, I look forward to much more collaboration with Dr. Chris Palmer, much appreciation for him coming onto the show. And I think if you guys have interest in this, look up his work at chrispalmermd.com and his work through McLean. But all of the publications are there that he has done. The case studies that we talked about are published there. It is striking stuff. If you know someone with bipolar disorder, if you know someone with psychotic disorder like schizophrenia, schizoaffective disorder, then this is really an important topic. And I cannot wait, like I said, to see the paradigm in psychiatry change, because the medications, like Dr. Palmer said, sometimes help some people retain some function or regain some function. But overall, mostly in psychiatry, we just make people fat and give them diabetes. And our paradigm really needs some assistance. And so this is really cool stuff. I've said that a million times. I'm clearly very stoked about it. So if you're interested, check out my work, check out the work of Dr. Chris Palmer, hopefully check out our future collaborations. Happening with me, I am getting so close to finishing this book, you guys. I cannot freaking wait to be done. The publisher is going to be Indigo River, so I have an amazing publisher that I'm working with. The book is coming out later this year or early next year in January. I'm hoping it's going to be later this year. The title is The Carnivore Code, and there is a website for it based on my website. My website is carnivoremd.com, where you can sign up for my newsletter, which is called The Fundamental Health Insider. And that is mostly what I'm working on these days. I'm working super hard on the book. It's going to be done very soon. And I've got some cool stuff coming up with White Oak Pastures and some other events. So you will see more about this White Oak Cella. For those of you who are not aware, Coachella is a music festival in the desert in California. And so we are calling this White Oak Cella. It's going to be in Bluffton, Georgia at the White Oak Pastures Farm, December 14th, 15th. We are going to have talks. I'm inviting all sorts of my friends, and I'm hoping some other awesome radical folks will show up. And I will keep you posted on who will be there to give talks. There are some, you're all awesome and radical folks listening to this, but I'm hoping that some of my other collaborators in the space will show up to give talks. The Strong Sisters will be there. Sarah and Ashley Armstrong, who I am writing a cookbook with. They are at Strong Sistas, Sistas on Instagram. If you don't know them, they are an awesome pair of sisters. Duh. And they're going to be there, and we're hoping to have some other cool folks there. Maybe I can get Ken Berry there, and we've got some other awesome invitations out. So I will keep you posted on that. There's going to be music, talks. We're going to do archery. There's going to be demonstrations on the farm. There's going to be a butchering demonstration. We're going to slow roast an animal. We are going to have a carnivore feast on Saturday the night, and we are going to have music, like I said, dancing. We will be steak dancing, and then we're going to have yoga on Sunday morning, and it's just going to be an awesome community experience and a celebration of regenerative farming and regenerative agriculture. So check this out. Stay posted. Stay tuned for all the details that are shown up. One of the things is that at White Oak Pastures in Bluffton, Georgia, there are cabins. I think those are all already booked, but there is a state park called Bagby State Park that's about 20 minutes away where people should look for accommodation if they want to come. And again, later this week, hopefully, or early next week, I will be posting tons more details about White Oak Chella. Like I said, my website is carnivoremd.com. Go there, sign up for my newsletter, The Fundamental Health Insider, and check out Ancestral Supplements and check out White Oak Pastures. Use the code CarnivoreMD there. They're an amazing spot. And thank you all for listening to this podcast. Please share it with your friends and family. This is game-changing stuff, you guys. All right, I appreciate you all. I talk fast because I'm just so excited, but I will see you guys soon. Stay radical.